sample should be carefully handled. You have only a few nodes to take care of. So what happens, you take a section across the node on the longitudinal axis and then make 3 sections or 2 millimeter slices across the longitudinal axis and then 3 sections across it also. So once you have done that, you have got a very detailed study of the lymph node. The drawback of having frozen section is that you can't have a very detailed study. So in that we do only 2 or 3 sections of a node depending on the size, and that is maybe a drawback of sentinel node. So at max we have had done 194 cases over 3 years. This was from 2010 to 2012. Now we have crossed about 400 cases. Now all patients we do by dual technique. The identification rate is about 97%, and all 5 patients had only blue nodes but no hot nodes. So this is also sometimes that you have only one odd node positive and the other node, one odd node which is showing only the blue dye and not picking up by the gamma probe, or the other way around also has happened. So average number of nodes is 3.67. We are more liberal in removing the nodes, I must confess, but it is desirable to have around 3 nodes and no major complications except occasional discoloration of urine. This is just to show that how the radioactive nuclear medicine department is injected, then the patient is taken to the OT and the blue dye is injected. This photograph was taken when we were doing over the tumor. Now we are routinely injecting the blue dye on the under the perioral complex, not on the tumor, because there the the skin necrosis rate was higher if you do over the tumor site. And once you have taken the patient table, use these 2 techniques. The counter is here. You see on the counter what you pick up with, and you have picked up only a sentinel node. No drains, nothing is required, just like any node biopsy, and that's good enough. So NSABP B32 shows that they did a study of 5,611 cases. They divided 2 groups, the sentinel node dissection plus lymph node dissection, and those who had only SLND, and if the node was positive, then you do a sentinel node dissection. And over a long period, over 6 years period, they found that almost 60% of these patients who had node positive had only 1 node positive in the axilla. So probably there is a scope that we can avoid any subsequent intervention in a large number of these patients. The risk of positive lymph node grows up in the presence of lymphovascular invasion. We also know that the risk of positive lymph node is decrease in the number of nodes picked up is high. 3 or more nodes is a good enough reason to have that we have a most good sensitivity. And the morbidity is low, though there is a learning curve to all this. So they also came out with a guideline to say that for the that if the sentinel node has macromets or micromets, a completion ALND should be done, and that is what is a routine we have been doing till now. However, we all know of this trial Z011 where they said the axillary dissection versus no axillary dissection in patients who had sentinel node metastasis. What they did here, they randomized these patients, only those who have had breast conservation surgery. This is where an important catch is, because in our practice, BCS rate is not as high as in the Western world. Now, once the BCS is done, if the nodes are positive, then they are randomized into axillary lymph node dissection completion or no further surgery. The idea was to study the effects of ALND on overall survival with sentinel lymph node positive patients with lumpectomy who are also having adjuvant systemic therapy. We know node positive patients will have definite systemic therapy and also radiation because of the BCS and also node positive today. The secondary objective obviously was to determine the effects and disease-free survival on the overall adding ALND to these patients. And the inclusion criteria, T2 downwards, T1 and T2 disease, no palpable lymphadenopathy, no and unicentric united disease, lumpectomy with negative margins as is the goal for the primary wide excision, and 1 to 2 sentinel node at least containing metastatic disease. They excluded the patients who had more than 3 nodes positive and or those who had extracapsular extension or those who had neoadjuvant chemotherapy or endocrine therapy. So once this subset of patients was identified, then the patients were categorized into those who had 1 node positive, 2 node positive, or 3 or more node positive. And these patients, as you are seeing the blue bar, that those who had full lymph node dissection and those who were trusted only with sentinel lymph node. So we see there is a comparable figure on both the arms. There were comparable number of patients who had either completion axillary dissection or did not have any axillary dissection. And what did they find at the end of 6 years? That the recurrence in the LND group was also quite low. In the local area, it's about, LND group was about 3.6% in the breast, and in sentinel node group alone, that means those who did not have a completion axillary dissection, about 2%. And if you look at the total control rate in the axilla, that was about 4% versus 3% in the 2 arms. So the axillary lymph node dissection group did not have any superior advantage over those who have had only the sentinel node sampling. And this is just to show that in the tangential field how the axilla is covered, the lower part of the axilla is covered in that. So that is adding to the improvement in local control rate. The 5-year survival rate and disease survival rate was also quite comparable in the two groups. So the conclusions were that SNB alone provides excellent local regional control comparable to SNB with completion ALND in patients with T1, T2 disease who have 1 to 2 nodes positive and who are going subsequently for adjuvant systemic therapy and radiation also. Now the third important question is whether there is an opportunity to actually avoid excision completely with radiation. Now this is a very important AMROS trial where they did a trial of patients in T1, T2 breast cancer with no palpable lymphadenopathy, and they randomized them into an open label study where they grouped into either axial dissection done or only radiation given to these patients. The primary endpoint was that a non-inferiority trial was there, that comparing whether radiation is not inferior to axial dissection. Out of this 4,823 patients enrolled from 34 centers, 4,806 were actually eligible for the randomization. Now 2,402 were randomly assigned to receive axial lymph node dissection, which is the standard of care as of today, and the remaining were subjected for radiotherapy. Now of these 1,425 patients with positive sentinel node, now this subset had sentinel node, positive sentinel node, 744 were assigned for completion axial dissection versus those who had only radiation in this group. Now at again 6.1 years, they found that patients with positive sentinel node in the axial lymph node dissection group, 222, who had underwent axial lymph node dissection had additional positive nodes. Somewhere around what we saw in the previous study also, that about 60-65% patients only had that sentinel node positive and the rest of the axilla was clean. Here again, about 33% who have additional nodes positive. The axillary recurrence occurred in 4 of these 744 patients. Now, in spite of having axillary complete dissection, 4 patients had axillary recurrence and 7 of the patients who had radiation therapy. The point is that almost similar number of patients would have axilla positive post-sentinel lymph node. Now, in that subset, if you give radiation, again the failure rate is quite comparable with radiation therapy, 3% versus 1%. So, no this difference in overall survival or local regional control.